This week on the BackTable Podcast.
We're all familiar with the AUA guidelines on recurrent UTIs, and the number one intervention for postmenopausal women with recurrent UTIs has been vaginal estrogen, and this guideline brings that to light again, that we should be offering vaginal estrogen for the treatment of that condition. And I think what's important to note is what Dr. Kaufman said earlier, is that there really isn't data that other therapies other than vaginal estrogen will treat those comorbid genitourinary conditions. So not the DHEA, not the moisturizers or the non-hormonal options. Really, if someone is coming to me with recurrent UTIs and urgency, frequency, dysphoria, and I diagnose them with GSM, I am really recommending a vaginal estrogen as an option because that is what the data shows will be effective. And there's really not data on the other treatments for those GSM-related symptoms.
I'm your host today, Dr. Suzette Sutherland, and I'm thrilled to have two guests here with us today, Dr. Melissa Kaufman from Vanderbilt University and Dr. Giulia Ippolito from the University of Michigan. They are both FPMRS, or female urology, urogynecology, and reconstructive surgeons and specialists in this area. And we're talking today about the brand new 2025 AUA SUFU guidelines dealing with genital urinary syndrome of menopause. That's a big mouthful, so we call it GSM. So our evidence-based clinical guidelines, how we should be finding these patients, diagnosing them, and then treating them. So we're excited to hear about these guidelines today. Both of our guests were very instrumental in formulating these guidelines, with Dr. Kaufman here as chair of the Guidelines Committee. So thanks for being with us here today, both of you.
Thank you so much for this opportunity, Suzette.
Yeah, thank you.
Dr. Kaufman, I'm going to start with you. With the being the chair of this committee, many of our listeners, I'm sure they utilize the AUA guidelines, SUFU guidelines, but don't even know how they get developed. You know, they really are evidence-based clinical guidelines based on the data that we have available in our literature. Can you describe what is that process like briefly, and how is the governance and oversight of that on your part as the chair?
Yeah, thank you so much for that question. At first, I really just wanted to give my deep appreciation to the American Urological Association for their really courageous decision to sponsor development of this guideline. Every practice guideline that we have comes from a clinical question and a need that urologists, primary care physicians, urogynecologists, gynecologists have out in practice as to how do we best treat this patient population. So the process of guideline development actually takes many years. In addition to having this burning clinical question, you then develop a set of questions that you want to ask of the literature. And then there is actually an evidence-based systematic review that a methodologist, and in this case, we utilize the Minnesota Evidence-Based Practice Center and the Agency for Healthcare Research and Quality, to provide this evidence base for which the guidelines were formed. We were also funded by the Patient-Centered Outcomes Research Institute, which is an enormously important avenue in order for us to get the best data possible. Then the panel is assembled once we have this data, and we go through every single article and every piece of data and allocate whether it meets the metrics for inclusion into the guidelines and what this looks like from a clinical, practical perspective. And you'll notice that in the guidelines, we make a number of different statements, and we make a strength to each one of those statements based upon the strength of the evidence that comes from the literature. So sometimes there will be something that is a clinical principle, meaning that there's not really going to be a lot of evidence in the literature. For example, that if a patient comes in with a particular condition, it is generally good clinical practice to perform a history and physical on that patient. So that would be a clinical principle. There's also expert opinions, and that's why we assemble the group that we do in the room, because we want to draw from all these different clinical scenarios and everyone's experience to be able to make judgments when there is not a strong evidence base. So it takes a many-year process with an enormous amount of pro bono work, but in the end, like, this is going to be a transformational guideline for the women that we treat. It provides a lot of pragmatic statements that can be rapidly implemented for evaluation, treatment, and in the end, we really, really endeavor to improve our patient outcomes.
Wonderful. Thank you. That was a great, thorough explanation and gives us some good background into what do these guidelines really represent. So I think we'll look really quickly. There are 26 guideline statements that came out of the literature and out of this evaluation of the literature, and they were put into different buckets. Interestingly, the largest bucket, I'm just going to list them here and then we'll get into them. We don't have time to address every one of them, but I think we can address each bucket in any case. So the first bucket is really screening and diagnosis. So clinical guidelines on what is the appropriate screening methodologies and diagnosis of this issue. And there are 7 guidelines for that. That was the largest category. There are 6 guidelines talking about hormonal interventions, 3 guidelines for non-hormonal interventions, 2 only based on energy-based interventions, so we know what we're talking about there. 5 for breast cancer and endometrial cancer risk. 1 endometrial surveillance, should we or shouldn't we, really is what it's answering. And then 2 guidelines even on follow-up. But we start women on treatment for GSM. How should we be monitoring them as time goes on? So I think let's start with what is GSM, genital syndrome or genital urinary syndrome of menopause? What are the symptoms of it? What causes it? How do we diagnose it? Dr. Ippolito, can you shed some light on that?
Yeah, absolutely. That is a great question. So genital urinary syndrome of menopause, or GSM, is a spectrum of symptoms and physical changes that are associated with declining estrogen and androgen levels, typically seen in peri- and postmenopausal women, but can also be found in other groups that are not traditionally peri- or postmenopausal. When I think about GSM, I think about symptoms and signs. So the guidelines has a really nice table that describes very simply for clinicians the symptoms and signs. So symptoms of GSM include vaginal dryness, decreased lubrication, discomfort with sexual activity or dyspareunia, postcoital bleeding, dysuria, urinary frequency, and irritation of the vulvovaginal area. What's really important as urologists is that dysuria, urinary frequency and urgency, recurrent UTIs, those all fall within GSM. So these are things that we see every day. So when we hear about those symptoms from our patients, then I always think about looking for the signs. So signs are found on physical exams. So the guidelines do recommend both a history and physical and also a genitourinary exam on patients who may have GSM. When we're doing the physical exam, what we're looking for are decreased moisture or loss of the vaginal rugae, which are the folds within the vagina, decreased elasticity, vulvar erythema, so thinning of the vulvar and vaginal skin. You can also see that there are urethral changes like urethral prolapse, or what some people call a carankle. These are all signs of GSM. And so when I think of GSM, I think of the symptoms and the signs, and I think that's the easiest way to put that together for clinicians.
Let me also discuss at this point when Dr. Ippolito mentioned that this was not just about women who were peri or postmenopausal. There's a whole other patient populations that this can apply to. And that includes women who are on systemic estrogen. So we very specifically made a guideline statement that women who are on systemic estrogen also may require treatment locally of some of this GSM. But this is also women who have other profound estrogen deficient states, like women who are on, say, treatments for breast cancer, aromatase inhibitors, and selective estrogen receptor modulators. Sometimes women that are breastfeeding women that are undergoing pelvic radiation or chemotherapy or other endocrine therapies for cancers, even some young women on oral contraceptives. All these people could benefit often from treatment from these types of GSM symptoms. So it is not just about a peri or postmenopausal woman.
That's super important. Thanks for pointing that out. And one of the other things that's mentioned in the screening and diagnosis section is that as actually educating patients that it's the lack of estrogen or a lack of, the way it puts it, sexual hormones, because it could be estrogen, progesterone, testosterone, but it's the lack of these hormones that contribute to all of these kinds of symptoms. And I think that's super important so people see, A can go to B, right? And it doesn't, as you say, have to be just in the scenario of postmenopausal situation. So great.
Yes, it's always about education for everyone, for all the providers that will be accessing these guidelines, and then putting it in the context that you can individualize this therapy for each patient's preference, because it's a very preference-sensitive condition.
The other thing I thought was very interesting that you maybe felt the need to add in the guidelines in the screening and diagnosis section is that when you find patients who also have some concomitant sexual health concerns, that you may refer to a credentialed therapist for a sex therapist. And the same was true for if you find some underlying pelvic floor dysfunction, that the recommendation, it says may refer to a physical therapist who specializes in this area. I found that interesting, the panel's sense that there was a need to make sure that when people make that diagnosis, it doesn't just stop there. What do you do with it? That it's your obligation to refer. Do either one of you want to comment on that a little more?
Well, we wanted to make this as multidisciplinary as possible and not just engaging, say, a patient's oncologist or primary care physician, but understanding the full range of particularly pelvic floor disorders that some of these patients may have, and to ensure that they had the appropriate type of triage and treatment. And, by calling out these things, it destigmatizes, right? It allows the patients to get the best treatment options without the fear of having it put into some other bucket, that some of their symptoms are psychosocial and these sexual health concerns are not legitimized. And so women have suffered from that type of marginalization for forever. And I think that these types of statements inserted within the guidelines, and the panel was very strong on these opinions, will get women to the appropriate providers in the quickest way possible.
You led with this on all of the statements. Statement number 1 is the importance of shared decision-making. We hear so much about that in every area these days, right? That it's important to educate the patient. And I think that puts the responsibility on the clinician to educate the patient enough that they can truly make an informed decision. And I think that's what you're saying here. Why is it so important, though, in this scenario with the use of hormones and such?
I'll take that one if that's okay. I feel very strongly about shared decision-making, and what shared decision-making means is balancing patients' preferences and values with the best available medical evidence. And what really an important piece of shared decision-making is that making sure that patients are informed before you elicit their preferences. So giving them options, educating about those options, and then asking them what's most important to them when making their decision. And I think that is important in the GSM guidelines, particularly because we have a situation where we have what's called clinical equipoise. So there's not necessarily one right answer. The evidence that we have in the literature doesn't say there's overwhelming evidence to support one treatment. What the evidence shows is there are multiple options for people to consider when treating their symptoms. And that is a situation where we must use shared decision-making because we cannot assume patients' preferences and values. And so giving people the option and informing them of the potential harms and benefits is what is recommended for high-quality patient-centered care.
Yeah, absolutely. Which takes us actually into our next area here, and this is why shared decision-making also is so important here, is because of the use of hormones, right? And the fear factor that has been established historically. This is part of a menopause series that we're doing at BackTable Urology. We've already recorded a few. One, we got into the history of the Women's Health Initiative, the DHEA studies, and, the confounding conclusions that came and inappropriate conclusions that came that initiated a number of myths about menopausal hormone therapy. We did that with Kelly Casperson, and we've also looked at what we're going to get into a little more here is the black box warning with respect to the use of estrogen products. We have Dr. Jair Santiago Lustra from UCSD, who's done a lot of work in this area, advocating the FDA to remove the black box warning from vaginal estrogen products. This is something that happened after the results from the WHI came out, the Women's Health Initiative that talked about the use of systemic estrogen and some of the potential problems that they attributed to the use of hormone replacement therapy, such as the risk of breast cancer, endometrial cancer, cardiovascular disorders such as stroke and MI, and even possible dementia. So that's the black box warning that's on all estrogen products, including all low-dose vaginal estrogen products, not just the systemic products. So there's a huge campaign advocating for removing that black box warning on all of these vaginal estrogen products. Dr. Santiago Lustra has been involved in this, as I said, so that's on another episode, as well as other people such as Rachel Rubens, Charles Powell, Erwin Goldstein, other people who've been on this panel even looking at GSM. So let's look at the guidelines that you were able to develop dealing with local vaginal estrogen. You came out and said clinicians should offer the option of local low-dose vaginal estrogen to all patients with GSM. You didn't say you may, or it might be nice if you said you should. So talk to us about that. Obviously, there was enough support in the literature to put a should in there. Dr. Kaufman, would you like to take that one?
Well, really, the evidence for use of local low-dose vaginal estrogen does have some inconsistencies and imprecision because of the way many of the trials were conducted. But despite those limitations, the panel very strongly recommended local low-dose vaginal estrogen for GSM symptoms due to its effectiveness combined with a very high margin of safety. As you mentioned, Dr. Jair Santiago Lustra has been working very hard to advocate for a change in that type of labeling. And it was way back in 2002 when this Women's Health Initiative was launched. And it was linked, the Women's Health Initiative initially linked estrogen and progestin in systemic levels to things like cardiovascular risk, breast cancer risk, dementia, thromboembolic disease. And a year later, that black box warning came out across all estrogens. And we do know now that subsequent evaluation of the WHI data showed no risk of breast cancer. Despite several petitions to remove that black box warning to the FDA, it remains. And so vaginal estrogen, low-dose vaginal estrogen, really is incorrectly grouped with these systemic therapies. And there's other analogs. Like we know that there was a trial, and it takes many thousands of patients to demonstrate this, for use of testosterone and cardiovascular risk. And so the FDA is amenable to changing labeling, but we still have an uphill battle to go with that. But we very strongly recommend, because of the safety profile that's been demonstrated for low-dose vaginal estrogen and the enormous benefit to patients, that the safety will oftentimes outweigh risk in the vast majority. And in other situations, as we'll talk about, it's going to be in the context of some multidisciplinary shared decision making.
And then how is it that the vaginal estrogen actually works? Why is it beneficial for the vaginal lining?
Yeah, that's a fantastic question. So it works in many different levels. The first of which is that it changes the vaginal pH. So it changes the acid base balance within the vagina and actually helps some of the healing processes go on because you are repopulating with what we would call our symbiotic bacteria that live within the vagina and the vestibule. So by changing this balance, it will actually change the way that the vaginal epithelium regenerates. And it's this regeneration that will eventually lead to tissue healing.
And so, from a real clinical, practical standpoint, perhaps Dr. Ippolito, how is it prescribed? How does it come? It comes in, I think we know, a cream, but are there other formularies, and how do we use it?
Sure. So vaginal estrogen comes in a vaginal cream, a vaginal tablet, and a vaginal ring. These have varying different prescribing options, but in general, for the creams and the tablets, clinicians are recommended like a loading dose. So usually it's every night for 14 nights and then twice a week thereafter. I remind my patients that we don't, in general, they're not developing any more estrogen. So once you stop the low-dose vaginal estrogen, the symptoms will return. So this is a forever medication if they are postmenopausal. The vaginal ring is placed in the vagina and exchanged every 3 months. I have a lot of patients who are institutionalized, are not able to do the vaginal creams or the tablets on their own. And so this is a really great option. Many of these women are suffering from recurrent UTIs or really bothersome vaginal irritation. And so actually, in my practice, many come to my office and we actually exchange their ring for them with my nurses. And this is, I think, a great service to these patients. The vaginal creams and the inserts can be applied either with an applicator. I do recommend the applicator because that is how they have been studied, but some people feel really uncomfortable with the use of the applicator. And then I recommend either using your finger, or there's several devices available to applicator type devices that are available. But any way that you're getting enough cream or of the tablet into the vagina, not on the vulvar skin, but actually into the lumen of the vagina, is what we recommend for those.
So, and it's important to say, except for Premarin cream, that all of the FDA-approved local vaginal estrogen options are estradiol, right? And so when I talk to patients too, I say it's the estrogen your ovaries would be making if they were still doing something. So it's probably the most natural thing we could be giving you, right? So with that in
100%.
mind, what do you think though about, I'm going to put it in air quotes. I know this is an AirPod and nobody can see me, but the supernatural compounding, right? Talk a little bit about that. I think that's a myth for patients, but many patients still come in and either are getting something from a compounding pharmacy or asking for it because it's much more natural. Speak to that, please.
Well, I do believe that there are certain iterations where some, despite the fact that there has been a marked shift in coverage for most vaginal estrogen products that are truly vaginal estrogens, there is still some insurance barriers and cost barriers for some patients. And so they can get compounded estrogens that may be more affordable than what would be available from a pharmaceutical. But what I think that you're referring to are other iterations that we would lump into the term of alternative therapies, right? And so we did address some of these in the guidelines, and unfortunately, there was just no data to support use with regards to GSM symptoms.
Yeah, so other types of supplements is what you're talking about.
Correct.
Right? But even with the compounding pharmacies, I guess I want to make the point too that they're not as regulated as something that's FDA approved. And so one batch that you get 1 month might not be the same batch the next month. And the pharmacist is doing the best that they can, or the compounding pharmacy there. But sometimes the products they get, they're not regulated. And so, you get more of the base and less of the medicine one time. And so it's not, as exact, I would say, and reliable, right? And from there, then maybe even a safety.
Absolutely true. And so that's why we are delighted that there have been a number of online low-cost pharmacies that have innovated, that have been huge supporters of this movement, who are now providing very low-cost vaginal estrogen.
To finish what you mentioned about the variation in dosing, I think one of the parts of shared decision making that I share with my patients, if there are concerns about estrogen levels or monitoring, the ones that have been studied the most are the tablets and the ring. And so if I have a particular patient that really wants to decrease any sort of risk from systemic absorption, the data that I provide is based on the rings or the tablets. And so I usually recommend going with one of those forms.
Right. And that's because it's just the smallest dose as well of estrogen, right? So for our listeners out there, both of those smaller amount of estrogen, 10 micrograms for the suppository. I forget what the daily dose is, maybe for the ring. But when you're using the estrogen cream, there's a little variability from one application to the next, and depending on how you use it, so it's not quite as exact, although it still can suffice. Can either of you talk a little bit about DHEA? That's gotten a lot more, publicity, I would say, amongst general patients and certainly at major guidelines. So let's talk about DHEA. That's an unknown to many clinicians.
Sure. So DHEA is pre-estrogen or pre-androgen, a substance that can be put into the vagina. And it's really interesting because it acts intracellularly. So your body takes it up into the cells and then breaks it down into estrogen and androgens. So this is particularly, again, recommended as an alternative for people who might not want to use vaginal estrogen, but does work intracellularly within the vagina to give a similar effect to vaginal estrogen. And it does not increase systemic estrogen levels because, again, it is broken down in the cells of the actual vagina, not cells other places in the body.
Good. And how about Ospemifene?
So Ospemifene is a SERM, so selective estrogen receptor modulator. I believe it is an agonist and an antagonist. And again, it is not an estrogen, but it works on the estrogen receptors to treat GSM symptoms. It is the only oral option in the guidelines and, to my knowledge, available for the treatment of GSM. So it is FDA approved for this. And so it provides an alternative to estrogen and to DHEA. It does have a black box warning that talks about thrombotic events and strokes and does require some monitoring. But overall, the guideline, which does a really great job going into the details of it, found that there's very few side effects with Ospemifene.
Yeah, so from a clinical guideline standpoint, it says we should be offering patients certainly low-dose vaginal estrogen, but also offering them DHEA. We may offer them Ospemifene. So I think it needs to be on everybody's, bag of tricks, so to speak, and everyone's armamentarium, not just the low-dose vaginal estrogen, but educate yourself about all three of these.
And some of it is predicated also on what symptoms you are trying to treat. So if you'll note in these guidelines, the DHEA and the Ospemifene are specifically for vulvovaginal dryness and dyspareunia, whereas we know that things like low-dose vaginal estrogens may be much more effective if the patient has recurrent urinary tract infections, overactive bladder-type symptoms, but these weren't studied in specific for those indications. May they work? Possibly, but we don't have that data set to make that statement.
I was just going to say that. We just don't know.
We just don't know, right?
So, Dr. Kaufman, I'm going to put you out on a limb here. Barring any other contraindications that an individual patient might have, what do you think would be the best first-line option? Low-dose vaginal estrogen, DHEA, or Ospemifene? If I could only have one in my office and I had to reach it off the shelf and give it to the patient.
I have such confidence in the response for low-dose vaginal estrogen. I also have confidence in the patient's ability to utilize the product because it's affordable. And because we can find several different formulations, so I want to make that as a shared decision with the patient, but I want to make it easy for her to apply and utilize. And I want it to be covered by her insurance or affordable. So because this is a lifelong treatment. So for me, it would be a local low-dose vaginal estrogen cream.
Dr. Ippolito, the idea of having other comorbidities associated with some of the local irritating symptoms, things like overactive bladder symptoms, or you already mentioned, that's why I'm directing this at you, recurrent urinary tract infections, right? So now you go out on a limb on the guidelines here and say that the local estrogen is really important for prevention of that. Can you talk a little bit more about how that came to be? It must be that there's enough evidence now in our literature to finally support it. Many of us have been doing it for years, but I'm so excited to see now that it's on the guidelines.
Yeah, 100%. So again, as clinicians in urology, we're often seeing women with the primary chief complaint of dysuria or urgency or frequency, and this might trigger us to go down the OAB guideline, which is absolutely correct. But it's important to remember that in people who have a low estrogen state, those symptoms might be really driven by GSM, and treating GSM might help us actually treat the underlying cause for those symptoms. So the panel has this really great guideline that says in patients with GSM and other conditions, you can offer low-dose vaginal estrogen to improve their genitourinary symptoms. And there is data behind this. So there have been studies that found that people who are randomized to vaginal estrogen versus an anticholinergic do just as well. There's also data to show that vaginal estrogen works synergistically with anticholinergics. So people who have both do better than people who have just one or the other. And that's definitely what I have seen in clinical practice. And so that's routine part of my treatment of OAB is to make sure I screen for and treat GSM at the same time. Similarly, we're all familiar with the AUA guidelines on recurrent UTIs, and the number one intervention for postmenopausal women with recurrent UTIs has been vaginal estrogen, and this guideline brings that to light again, that we should, again, be offering vaginal estrogen for the treatment of that condition. And I think what's important to note is what Dr. Kaufman said earlier is that there really isn't data that other therapies other than vaginal estrogen will treat those comorbid genitourinary conditions. So not the DHEA, not the moisturizers or the non-hormonal options. Really, if someone is coming to me with recurrent UTIs and urgency, frequency, dysuria, and I diagnose them with GSM, I am really recommending a vaginal estrogen as an option because that is what the data shows will be effective. And there's really not data on the other treatments for those GSM-related symptoms.
With that in mind, we get into the next category, the non-hormonal interventions. And it does say on the guidelines that clinicians should recommend the use of vaginal moisturizers and or lubricants, either alone or in combination, as you said, to improve vaginal dryness and dyspareunia. Again, being real specific about those two things as opposed to some of the other things we were just talking about, OAB and recurrent UTIs. So, yeah, Dr. Kaufman, can you comment on that? When we say vaginal, well, first of all, for our audience, what is the difference between vaginal estrogen, vaginal moisturizer, and a lubricant?
That's an excellent question. And, oftentimes I will say that we would recommend all three based on the patient's symptoms and their needs. But in general, like a moisturizer is a product that is intended to be applied that really mimics natural secretions of what you would anticipate from estrogenized vaginal tissue. And it's independent of use during sexual activity, whereas a lubricant is really one that's used as needed for short-term relief or discomfort during sexual activity. And so moisturizers may be applied daily or multiple times per day, and they're often used in addition to vaginal estrogen products. And then for sexual activity, a lubricant may be added on top of that.
So I guess a good clinical question for people who are listening. So I don't know how much data there was to support utilizing the estrogen twice a week, like we do for regular maintenance, and then suggesting if there's, I guess, for everybody versus they still have a little bit of local irritative symptoms, then a moisturizer on the non-estrogen days. Is that how it's meant to be utilized?
Well, we didn't really have any data for that type of guidance. So whatever we would give you as far as it would be our own clinical practice. And in fact, I think that people who we often will suggest moisturizers to be used daily or multiple times per day, in addition to 2 to 3 times a week vaginal estrogens.
Yeah. Especially for symptomatic patients, right? Having local burning, irritation, so on and so forth, for relief of that local.
There is very low risk to that. And as long as it is a robust product that they have confidence in and that has shown efficacy for them, there's very low risk.
The other big non-hormonal bucket that everyone wants to know more about and understand is this idea of utilizing laser, because it is skin and we laser lots of things, our face and so on and so forth. So can we rejuvenate by lasering the vagina? I'm going to throw that one to you, Dr. Ippolito. What do the guidelines say and what'd you find?
So great question. So the guidelines say that the evidence does not support the use of CO2 laser or ER-YAG laser or radiofrequency for the treatment of GSM. And the reason for this guideline, there are 11 studies that looked at this, and the data found that compared to sham, there was little to no improvement in treatment for these symptoms. There were studies that compared vaginal lasers to estrogen that found that there may be no difference between vaginal estrogen and laser. And so that after a lot of consideration, the panel placed a statement that says that in the context of shared decision-making and with the disclosure that these therapies are considered experimental outside of clinical trials, clinicians can consider CO2 laser treatments in patients who are not candidates or prefer alternative to FDA-approved treatments like the ones we've previously been talking about.
So specifically, if I can say, the guidelines then are calling out the CO2 laser as opposed to the other YAG laser. Is that correct?
Yeah, so the majority of evidence on this topic is based on CO2 laser. So there's only one study that looked at radiofrequency ablation, and I think 3 or less studies that looked at ER-YAG. So the rest of the 11 were from CO2 laser. And the CO2 laser studies were the ones that specifically compared against vaginal estrogen, which is where that statement comes from. I do think it's really important for listeners to be aware that the FDA has put out a warning against the use of energy-based vaginal lasers for the treatment of what they call vaginal rejuvenation. And they did send a lot of letters, I believe around 2018, to device manufacturers warning them against inappropriate marketing of their lasers for this use. So currently in the United States, as far as I'm aware, the FDA, again, considers the use of vaginal lasers for this indication experimental and should only be done by trained clinicians within the context of a trial.
So it should be the point made that the warning isn't there because there's a safety concern, at least that they know of, that the warning is there because inappropriate marketing. There's no data to support the marketing claim, right, for this rejuvenation. That's what you're saying.
So when the warning came out, I believe there were some safety concerns of burns and dyspareunia that spurred them to look closer. And again, this is my understanding of what I've read from the FDA, not part of the guideline. And then when they looked at the marketing, they saw that it was being marketed for something that was not FDA approved. Vaginal lasers are approved for ablation of various skin conditions, and that's what they were approved for within the vaginal space. And they have not been FDA approved for these non-ablative uses.
Yeah. So, I mean, as clinicians, we often hear of anecdotal reports or might talk to somebody who who's a clinician who utilizes this and says that they swear by it, it's working for their patients, but I haven't spoken to those patients a lot. And I think there's a lot of financial incentive also for the use of these lasers. And there may be a role in the future. We just haven't really been able to parcel it out yet and really identify what's a safe role in this area. So moving on to the next big topic, this is the main topic here that everyone's all worried about: estrogen use and the risk of breast cancer. And you put it together with the risk of endometrial cancer, and going right out and saying that in the literature, at least our review shows there's no link to low-dose vaginal estrogen use when it's used appropriately in a low dose, right? And cancer risk, endometrial cancer risk, and breast cancer risk, or endometrial proliferation, or atypia, or endometrial cancer. So, and that was the same for the use of DHEA, and I believe it was also the same for Ospemifene. So that was really great that the guidelines could come out and make that statement definitively, because that's the main thing that patients are always so afraid of, and even clinicians. Can you tell us a little bit, Dr. Kaufman, maybe even some of the literature that you looked at that looks at patients who've had breast cancer?
Yeah, unfortunately, breast cancer was not an endpoint for the evidence report to develop the guidelines. So we did interrogate an additional set of literature, because what we looked at for endpoints in the guideline were very specific to menopausal symptoms, and breast cancer, endometrial cancer aren't part of that. But there is certainly a large growing body of evidence that local low-dose vaginal estrogen does not increase the risk for primary breast cancer. So if you'll see these statements, they are expert opinions based on very large studies from the National Cancer Institute, the Women's Health Initiative observational study. It was over 45,000 women that demonstrated these low-dose vaginal estrogens do not precipitate risk. Now, if you look even at women who have had breast cancer, what we did was very thoughtfully put in there that it's in the context of multidisciplinary shared decision-making. Because some women, no matter what kind of safety profile, knowing that they've had an estrogen receptor positive cancer, may not want to embark on having vaginal estrogen or any hormonal therapies. And so, again, this is a shared decision-making, ensuring that you've got their oncologist who giving permission to embark on this therapy, as well as the patient, taking into this as a preference-sensitive condition and what other options may be available for them. This was also for women who were on tamoxifen, who were actively being treated to suppress estrogen with a selective estrogen receptor modulator. So again, there may be some pause for women on aromatase inhibitors, because there is some data to suggest not mortality, but a potential in one study for an increase in recurrence, which no one wants. So again, these are shared decision-making processes based on that patient's individual risk as well as their symptoms, and the intervention and the interplay between those two to try to make a decision on what's going to be appropriate for that patient.
And I think the tide is really changing, or has changed already to some degree. And we've been doing this kind of clinical work long enough to know the days when the oncologist would say, you had breast cancer, especially if it was ER/PR positive, you should never even think about estrogen, let alone utilize it, right? And the women were just so fearful, and you could not talk them into it. And sometimes even having a discussion with the oncologist then, and they still said, no way, no way, no way. Today, I have yet to find an oncologist that says no way. Most of them will educate the patient as well when they ask. Some of them who've been a little bit more skeptical, usually they're older oncologists, but, I'm able to talk to them and get them around, right? And so it's really nice to see that people are really looking at a lot of this data, the more contemporary data, and looking at it closely and utilizing it.
And it does help to have these guidelines, because it serves as a talking point for those conversations. Already, I've sent this guideline to several colleagues and say, my recommendation is based on the new AUA guidelines that go into this evidence. Can we have a discussion about this? And I actually print this and give it to my patients. I think it's really written in a way that everybody can understand, especially these statements are extremely clear.
Yes, I would agree with that. The statements are very clear. So that takes us to the next category, really, endometrial surveillance, right? And you go ahead and say many clinicians who don't dabble in this all the time, they wonder, do I have to check a woman every time before I start vaginal estrogen? What's the answer to that?
No.
So the answer is no.
Very good. Moving on.
But
no.
But it is really important. It is really important. I think about this a little bit like gross hematuria. So post-menopausal bleeding in a woman needs to be worked up, period. And to me, as a urologist, that's very much like gross hematuria needs to be worked up. Even if it's someone who has been on vaginal estrogen and has bleeding, or before you start it, if there's ever a postmenopausal person that tells you they have vaginal bleeding and that hasn't been worked up, it is our imperative as clinicians to work that up. Or if you're not comfortable doing that workup, referring them to a clinician that can do that.
And this is irregardless of any patient utilizing low-dose vaginal estrogen.
Yeah.
This is for any
Everybody.
patient that you encounter should undergo an evaluation for postmenopausal bleeding.
Right. So not only is surveillance before starting it not necessary, but surveillance during it on an annual basis is absolutely not necessary. The sentinel sign there's a problem is bleeding.
Correct.
Right? Just like in the bladder. Good. And then the last category here is really follow-up. I thought that this was really wonderful to add this to the guidelines to say, okay, you've started this or you've worked this person up and initiated something. What do? We don't just send them on their way and never address anything again. So, Dr. Ippolito, can you look at that practically? How do we monitor people?
So when I'm seeing someone for the first time and starting them on vaginal estrogen, I usually see them back in 3 months because I let them know it takes about 1 to 2 months to notice any difference. And by 3 months of regular use, we should be noticing a change in their symptoms. And so I want to see them back at that point, and then usually annually.
Do you think that that's true of all of the GSM-related symptoms, or... I mean, I find that sometimes if they have local irritation and they use especially the cream, that they get a little bit sooner, some benefit, although I do let them understand the estrogen's getting in there to tell the cells to turn over and make nice, healthy cells, and that takes time. So I like your answer of, 2 to 3 months before you're really good to go kind of thing, and then on maintenance. But
I think for especially the genitourinary symptoms, which is primarily what people are, their first reason they're coming to a urologist, I think it takes a little bit longer than for the dryness symptoms. And so usually it's about 3 months that I've noticed. I also do think, going back to the question about using moisturizers with estrogen, sometimes it's helpful when they're getting started to say, use the moisturizer, for that first month or two that it's taking you, the vaginal estrogen, to do its thing. And so sometimes I do that as like an on-ramp, and maybe they decide that in the long run, they might not want to do the vaginal moisturizer.
Yeah. And then the other aspect of this in the follow-up is that this is truly ongoing therapy, and making sure the patients understand that, right? They stop using it, you lose the benefit, right? Maybe not immediately tomorrow or the next day, but just like it takes a while to see the benefit, it takes a while to lose it again and get back to that atrophy and all those symptoms. But unfortunately, so many patients, when I see them and I'll say, have you ever been on vaginal estrogen? They'll say, oh, I did that for a while. I did that for a month, but I didn't see much, so I stopped and I didn't do it. Or I hear this story, oh, I did that for about a year and things were really good, so I didn't need it anymore. But now they're here with all those same complaints to see me now, right? So it is ongoing therapy for sure. Keep that tissue healthy. Very good. Well, I mean, I wanted to actually, we touched a little bit on that black box warning and the efforts that are happening here, and specifically around the vaginal estrogen use and trying to separate from the systemic estrogen use, even though there's a lot of data today to show that in the right patients is no risk, real risk of breast or endometrial cancer. But that's another fight. But right now, it's just about trying to get the FDA to understand that these are very different compartments and different dosing, right? Systemic versus local vaginal. And the safety over and over again that's shown in our literature of the local vaginal estrogen. And really, somebody said to me not too long ago, she just had her 65th birthday, and she said, she's a clinician too and works in this space. And she said, if I could advocate two things to everybody, all my friends and all my patients, it's strength training and vaginal estrogen. And I thought, there you go. Very good.
Hear, hear. And it's going to take some true collaborative efforts with all our professional organizations to advocate for these women, because it's going to be a combination of public campaigns, citizen petitions, those types of metrics that the FDA will eventually listen to. I mean, one of the things that we did highlight in the guidelines is the limitation of the data sets that we have for evaluation. Like, there is not a great deal of very, very high level data. And some of it is because we haven't had this language of genitourinary syndrome of menopause until 2014. It was called a whole suite of different things before that time. So we really need to focus on developing this data set to drive these next interventions and to drive the next set of regulatory environments for liberalizing use for patients.
Well, thank you to the both of you, Dr. Kaufman, Dr. Ippolito. We're just excited to have you on today and share your knowledge with us about these guidelines, the process and the conclusions, and what we can be doing as clinicians utilizing these guidelines to really help our patients. So thank you once again for sharing your expertise with us. We're happy to have you.
Thank you so much.
Thank you so much. And thank you on behalf of all the patients that will be impacted by this discussion and by these guidelines. Really, it's the increased education and awareness that is going to give us a whole new language and to influence patient care on a really global perspective.
Amen. Yes. Well, thank you to everyone who's listening. Again, this is part of our BackTable Urology Menopause series, so please check out some of the other episodes that we've already recorded, and a few more will be coming down the pike here. Again, I'm Suzette Sutherland, signing off.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.